Hello and welcome to the Chime Innovation Virtual Summit, AI, Cybersecurity, and the Future of Healthcare. Today we're going to explore transformative AI strategies and delve into emerging technology solutions that promise to transform health and care. We'll discuss why Think Differently is the only AI strategy you need right now. We'll gain some insights from our panelists on the topics of augmented virtual care. We're going to explore some old but also new innovation strategies and discover why customer experience, not digital technology, is pivotal in the new healthcare paradigm. I'm Keith Friedenberg, Executive Vice President, Chief Operating and Innovation Officer at Chime, and it's my great pleasure to welcome you here today. This virtual innovation summit would not be possible without the amazing support of our program sponsors. AvaSure, today modern patient care doesn't stop at the bedside. AvaSure's intelligent platform seamlessly blends remote and in-person care with AI-powered virtual sitting and virtual nursing. Thank you to AvaSure. Thank you also to Microsoft, who recently announced a new cybersecurity program aimed at supporting hospitals that serve more than 60 million people living in rural America. Cybersecurity attacks continue to disrupt healthcare across the country and pose a direct threat to patient care. Our rural communities are most at risk for these potentially devastating attacks. Chime applauds the efforts of Microsoft and many other organizations who are taking steps to help our rural healthcare organizations identify and stop those threats before they can cause harm. And finally, thank you to Nordic. Nordic helps healthcare leaders harness the power of technology so the people they care for can thrive. Combining deep clinical experience with extensive technical knowledge, Nordic helps their clients solve the most complex IT challenges, makes technology more useful for care teams, and more beneficial to the business. All right, here's a quick look at the agenda for today's summit. We've got a fantastic program lined up for you, and we're going to kick things off here with a bang in just a few minutes when I introduce our opening keynote speaker. Before we begin, let's cover a few basic housekeeping items. Keep in mind that you can use your attendee link to come in and out of the summit as your schedule allows. Every session today is live, but we are recording the entire program. So if you miss something, you'll have an opportunity to catch up later. We'll send a link out for all the recorded sessions to all of our registered attendees at the end of the program. But again, feel free to drop in and out as your schedule allows you to participate today. Please note also that we're going to be taking very short 5-minute breaks in between each of the live sessions today. So feel free to use that time, stretch, hydrate, catch up on messages, whatever you need to do before that next live session begins. And finally, unfortunately, due to time constraints, there's no formal Q&A for today's summit. However, you can use a Q&A function on Zoom to actually send us a question. And if we have a minute or two at the end of the session, we'll try and pose that to our speakers, our panelists today. If not, we'll circle back with you following the summit, and we'll also share contact information for all of our speakers today if you want to follow up with them at the conclusion of the program. Okay, we've got the housekeeping items out of the way. And it's my absolute pleasure to introduce our opening keynote speaker to get things kicked off. Aaron Murray is no stranger to thinking differently or AI. He's a healthcare leader and a Chime board member, but Aaron's also been pushing the envelope on what's possible for years. He's an early adopter to embrace and explore transformative power of AI in healthcare to enhance healthcare operations, reduce clinician burden, and improve patient care and deliver better outcomes. His thought-provoking keynote session, I think, will inspire you to rethink your approach to technology and healthcare transformation. I'm absolutely thrilled to welcome our opening keynote speaker, Aaron Murray, Senior Vice President and Chief Digital and Information Officer at Baptist Health in Jacksonville, Florida. Aaron, thanks for joining us today and kicking off the summit. We're excited to have you here.
Thanks so much, Keith. Appreciate it. And thanks for all of you for listening today and for all the speakers to come today and talk to you about AI and some of the things going on with AI. And so to set the stage, exactly as Keith said, what we have found here at Baptist and what has worked at numerous health systems, you see every day the massive trade regs highlighting work that's going on, is people thinking different, looking at problems and trying to dissect them in different ways. And it comes down to the old adage of process, then technology, people, then technology. So when you start looking at that and start thinking about how do I actually get that secret sauce to make things work, it always comes down to those basic tenets, your processes and your people, then the tech. So today I'm going to walk you through a couple of examples of things that we have done here at Baptist that really took us thinking differently to solve the problem. Could we have done it with traditional tooling? Could we have done it maybe with other technology? Perhaps. But at the end of the day, we had to solve with the why, answer the why, define the why, solve for those processes first, and then implement the tooling. And so we're going to walk through the challenges that we were facing, how we went about solving it, and what did we actually net result. I'm a big fan of talking about stories, things that have happened, things that either worked well or blew up in our face. That's okay too. But really sharing that back with you so you can take those material items home and learn from them and grow from them. And I'll say it up front and I'll say at the very end of this discussion, I am always accessible. I am always happy to do follow-ups and detailed conversations. I'm always willing to share my team with you all so that you can learn and go about the journey the same way. Let's get started though. Next slide. All right. So thinking differently, right? I always tell this to my team, what worked before won't work now. And why is this important? Because when you think about legacy technology of the way CIOs have grown up in the community, it really started with those early entrails of get electronic health records in there, get things digitized, do this fancy thing called PACS systems and digital imaging. It really wasn't about optimization of workflow or whatever else. So if you think legacy, right, you would think, oh, I'm just going to buy this tool off the shelf, slam it in, the problem is solved. That's not how it works. So what worked before won't work now. Secondly, we have to be comfortable this day and age asking questions and thinking differently. Now, that's an old adage that we've all said for many years, but let's be honest. In healthcare, we're very comfortable with repetition, and we've always done it this way. Sometimes change can be a Herculean effort. But you have to have the courage and conviction to ask those questions and make sure that everybody in the room together is partnering and asking the why and really working to make things happen. Next slide. So the first challenge we're going to talk about in really looking at is really leveraging machine learning and predictive analytics for improved utilization in our operating rooms, right, in infusion center. This is a very common problem that we all have, which is we don't want schedules for the OR that go unused and blocks going unused. We don't want patients to be waiting in the waiting room going, gosh, when am I going to get in for XYZ procedure? And if you need infusion, for goodness sake, we want to make sure that you're getting that as soon as possible and maximizing the resources we have. So the first case study is all about, call it intelligent hospital operations, right? Which takes a multidisciplinary group working together. The second thing we're going to talk to is something very sad, but very near and dear to my heart in terms of how I feel about this, which is that we have to do more when it comes to leveraging AI to fight this terrible plague of human trafficking. I'm going to walk you through what was going on here at Jacksonville, how we solve that, and how we really put emphasis behind making sure we mitigate this problem as best we can and save lives. Next slide. Okay, so rethinking scheduling. This is a multifaceted, everybody has this problem. I don't think there's anybody I've ever talked to that said, oh, we've got a perfect OR schedule, or we've got a perfect infusion chair schedule, or whatever it may be. It doesn't happen. So we were not managing patient flow and facility utilization appropriately. There were ongoing challenges. Obviously, we had a disconnect between what our surgeons expected, what our circulators expected, what our operators expected. Our technology stack wasn't optimized for it. We weren't seeing the data. Things were going idle, so we had rooms that were basically sitting still, which is a terrible situation when it comes to hospital operations. Our providers were just angry and taking their cases other places, especially for our docs that are splitters, right? They were taking cases of other health systems because they couldn't get in, right? We couldn't get somebody in for a hip replacement for weeks, and that's not going to work. Our infusion center wait times were off the charts, leading to major dissatisfaction. And of course, our staff was upset because they were working odd hours trying to catch up and trying to make it right. The one thing I've always seen in a medical center is that your nurses and docs will do anything they possibly can for the patient. That's it. That is the most important thing to them. So if your tech and your processes are getting in the way, guess what? They're going to go around it and it's going to blow everything up because they're going to make sure that patient gets the care they need. So you have to work together. So we work together to put in a predictive analytics solution to really re-examine looking at our people and processes, to integrate with electronic health record, right? And make sure that we are putting robust dashboards and other things out there so people could utilize it, right? At the end of the day, we were looking for actionable data to really allow for continuous improvement. Why is this important? Because a learning health system is constantly evolving. It's constantly iterating. is constantly looking at itself going, what can I do? Predictive algorithms behind the scenes help to basically get you to that next level faster and more cleanly and successfully. So you have to do all of it, from a data cleanliness to a process improvement to people that are aligned in what you're doing, to make sure those dashboards and those analytics and those insights and prompts make sense. So what happened with us? Next slide. So objectives, again, we talked about it, right? Utilizing the OR, access, et cetera, et cetera. I don't want to go through all these again, but the reality was the hospital operators and our surgeons were looking for more OR utilization. Fun fact about Jacksonville, Florida, is there's about 150 people a day moving to this region. We've got new rooftops going up, which means demand is through the roof. I can't build hospitals fast enough to keep up with demand, so we have to make sure we are maximizing utilization. So you had new surgeons building practices, surgeons coming in here trying to bring cases in. Then, of course, for the OR, we had surgeons that had block time going unused. It's amazing how generous some procedures may think a case takes. So what does that actually mean? And then we had robots that were going unused, or robots being used for non-robotic procedures, which from a surgical perspective leads to really wonky outcomes and not the type of efficiency and effectiveness you should be looking for. So historical 44% primetime utilizations, and they did not have access to the OR. It was terrible, terrible utilization. Next slide. So what are the results? Right? I think it's important we look at results. We put in our solution in FY21. Well, what was going on in fiscal year 21? This little thing called the pandemic was going on. So not only were we now using our solutions to make sure we're optimizing the OR, remember, a lot of us were, especially someone like Baptist, which has a PSA that goes from basically south of Atlanta to north of Orlando and out towards Tallahassee. We were shutting down hospitals in various zip codes, moving people from one place to another. Florida was open a little bit more than other states during that time, but we had to maximize our ORs, not just because of what I told you historically, but because we were moving people from one place to another. We didn't want to lose that case volume and really fall behind from a financial perspective. And we wanted to make sure people were able to get their cases. So even in FY21, right, then look at the number of increases of a percentage of cases that we had there, right? 47.4 thousand cases, right? Between 2 years later, we're at 50,000. Same number of ORs. We didn't expand our OR capacity right that time. We have recently. But to the degree of it, we were able to do a 6%, over a 6% increase simply because of algorithmic processes and data insights that allowed us to see that. The algorithms we built allowed us to start prompting and nudging folks going, hey, I know you scheduled 6 hours for a TKR, total knee replacement, but you really need 4 hours, on this robot, et cetera, et cetera. Those are the kinds of insights over time with data and analysis that we're able to provide, and then build the algorithms and logic behind the scenes to prompt our surgeons and prompt our OR teams to be able to get in front of that. Look at the next bullet there, right? Almost 460,000 increased case minutes from FY21 to 23. Think about that. That's that many more procedures we can see for the same block utilizations that we had before. So we unlocked 8,500 hours of approved releases, meaning, yes, you can go do this case. Yes, you can do this case. And it increased 11,000 hours of requests through that, right? So access was increased, right? We opened sooner, meaning you're able to get into the ORs faster with your cases. So 23 days sooner. Think of you waiting for 23 days in pain longer because we didn't have this before. And securing days, right? So when the surgeon asked for that OR slot, we were telling him before, you got to wait till next month, man. Sorry. Now we're able to get them in almost real time to when their case was scheduled, right? Depending on preference and location, et cetera. So to the degree of it, from a hospital operations perspective, this is a multifaceted operational journey to get everybody in line using AI and ML behind the scenes, but really about the process and people behind the scenes. We were able to achieve this. Now, I would be remiss and say it is not the tech. And I will tell you again, it's not the technology. It's what went into the technology. That's what's called thinking differently. That's what's saying that what worked before won't work now. That's what's called asking the right questions and then creating an environment that's safe to ask questions. Next slide. Infusion centers. I alluded to this earlier. Right, we had bottlenecks during the midday. Everybody was coming in for infusion chairs at that point, right? We had patient wait times, drug wait times, because they were compounding in the pharmacy or setting up the bags or whatever it may be that were delayed, right? Almost just as bad, if not worse, The staff were not able to take lunch. Now, I don't know about you all, but if I don't at least get like an apple or something during lunch, I get pretty hangry. Imagine when you're seeing dozens and dozens of patients on a panel, or your infusion chairs are backed up and you've got patients that are hangry, you're hangry. That's not going to work, right? So that was a bullet point to allow us to create time space block so that our staff, which were getting burned out, could have their lunch. Very simple request. But you'd be amazed at how often lunch is sacrificed by a caregiver because they're going to put that patient first before themselves. So nurses' objectives, get that 30-minute time for lunch, distributed workload, et cetera, and decrease wait times to less than 15 minutes, right? So we used our historical data to understand capacity. We built templates and using machine learning to give us trend and optimization. We had over 80% adherence to templates when doing scheduling because of this. And then we were able to refine our daily huddles because of this also. So what did this do for us for Infusion? Next slide. This is what had happened, right? Look at this, right? We went from 2019, 2020 time to an average wait time of 18 minutes down to 14 minutes, right? Over 40% folks waiting were over 15 minutes down to 35%. And a lot of that's because of chair utilization and types of chairs, particularly our pediatric patients, right? Look at that. Look at on the fourth column there, right? 19 minutes average wait time during peak hours down to 16 minutes. That 3 minutes adds up per patient. Think about that during the course of the day. So we get a 30% decrease in chair wait times and a 20% decrease in drug wait times, all because of this process for infusion chairs. But what does that equate to? Next slide. So overall, when you look at just infusion, right? And from 2018, 2019 timeframe forward for doing this, we estimate just infusion alone, it's been about a $40 million uplift to the health system. Just infusion, just with AI, just with being able to do this and increase patient sat. This is not the soft cost positive knock-on effects of a happier patient leads to better HCAHPS potentially, or leads to better net promoter scores down the line. Put that all aside. I'm talking about cash in the door, which for any of you that are finance background will be, or you report to a CFO or work with a traditional CFO, be like, great, cash is king. This is material, right? AI leads to material outcomes, leads to material processes. Next slide. All right. Told you this is near and dear to my heart because I think it's horrific, the situation of what's happening across this country and across the globe. So if you think about Jacksonville, Florida, where we're located, first of all, we're in Florida, which ranks third for human trafficking cases, which is just abysmal. I moved here to Florida 3 years ago from Texas, and we also had this problem there. But in Florida, it's really, really sad what's going on. Most of the victims come in contact with healthcare. And then our Baptist electronic health record did not have any tools to help us identify victims. So we were having victims present and leave, but all the telltale signs, we were not picking up on them because of the volume of patients and what was going on. So I give full credit to our nursing staff who said, you know what, we're in Jacksonville. Jacksonville is at the intersection of I-95, which runs up the Eastern Corridor, and I-10, which runs from basically Jacksonville all the way to California. And we have one of the largest seaports in the country. We have a very robust airport, and we connect Atlanta to Orlando to Miami. So you imagine how much traffic is going on the roads and how many people pass through. True story, our pediatric emergency department, right? This is at our Baptist South location, were the ones who came up with this. The nurses were fed up with the fact that these victims were coming in and they weren't able to always spot them, because some of these victims have been sadly coached and rehearsed how to not look like or appear the victims of trafficking, right? They have some other ailment in there and they weren't picking up on it intuitively. Could our electronic health record and AI tools help pick that up based upon cues and other types of questions, prompting the nurse to ask the right questions? Next slide. The answer is yes. The clinical leadership team decided to dig into this. This is actually our flow chart on the right-hand side of how this works, I suspect. We built a model because there was no model at all on several indicators of human trafficking, and all the patients that present to the emergency department were required completing by a nurse. Also, maybe even an element that's even more sad to this thing was these were pediatric trafficking patients that we're seeing through the door. And not to dismiss adult trafficking, but this is even worse. We were having children present and we couldn't even tell what was happening. So we built this tool, right, with pediatric patients in mind, knowing it's extensible to adults, to say, what can we do? And this is exactly the flow chart of what happened. And I told you before, it's process and people before the tech, right? We had the tech. Could we figure out the process to build this out and do it? Next slide. Yes. So this is an actual screenshot. This is obviously a test patient. So for anybody in compliance, it's test patient. But this is actually what it looks like from our ED narrator screen, right? Yes triggers, basically yes, no's, and indicators across the board. Red flags for the nurse to be able to say, ask this question, ask this question. We're currently at 93% compliance with the tool for our pediatric ED, 84% for adult. We're always learning. This has been live since about Valentine's Day this year. And we've been identifying several potential patients, implementation less than a year ago. The day this went live, which was right before Valentine's Day, we had a couple of people present. They were luckily spotted because we have very sharp nurses, which they're all smart, but very sharp nurses here at Baptist. This tool goes live. The next day at one of our freestanding emergency departments, in walks a 17-year-old girl who was being trafficked. This tool caught her. We were able to recuse her and save her. So if that is not power in itself, that AI, when coupled with the right process and people that support it and anchor it, I don't know what else is. Next slide. All right. So at this point, I will leave you open for some questions. I know we've got about 3 minutes left, Keith, give or take, but
Yeah.
I want to anchor this with people and process, then the tech. Go for it, Keith.
Thanks very much, Aaron. We do have a couple of minutes, so if you're willing to maybe answer a couple of questions,
yeah.
I want to go back to the OR utilization use case. You had some really great statistics there in terms of how you were able to increase OR utilization. I want to ask you though, did you go back and actually talk to the surgeons, and did their satisfaction scores go up as well? Were they happier?
They were, and actually interesting you say that. We have our latest physicians engagement scores we got yesterday, and one of those is your happiness with the OR operating rooms. That's everything, materials, supplies, everything, but it's exceptionally more than what it was years ago, and we track that year over year. So the answer is yes. We talk to them one-on-one. We have a good clinical informatics team that rounds with them and talks to them one-on-one as a surgeon. But then also when they're allowed to anonymously, basically blast you with water or give you kudos, they give us kudos. So I take that as a summation of, yes, we are on the right track. I don't think there's anybody that's 100% happy. I don't think that's possible, Keith, to be honest with you. But I do think that we are absolutely on the right track, leveraging tech to enable patient care.
Yeah, that's awesome. On your second use case, and wow, this is a really tough one. Human trafficking is just such a horrible issue, but the fact that you were able to actually get the right people together, right? It wasn't a technology issue, right? But it's about the process, leveraging the technology then to help you spot and identify those red flags. You mentioned an individual whose life you may have saved.
Right.
Have you shared any of what you're doing with other organizations, or you have?
We have, and in fact, I'm really, my team is just phenomenal at this. They've actually presented at our electronic health record user symposium.
Yeah.
We've been sharing stories with folks. I know the hospitals in the area, those CIOs have reached out to me. We've shared with them. For any of you in an area that you know that you have this challenge, reach out. We're happy to give you a copy of the algorithm and the templates and the questionnaires. This, to me, I hope is added as a standard package in the future for electronic health record. This problem is not going away. It's getting worse. And we have the power and the tooling now to use insights to help mitigate this problem.
Yeah, thanks for that. Thanks for sharing the work that you're doing with others and having that willingness to help everybody fight back in this horrible problem. We've got about a minute left here, Aaron. I had the opportunity last week to host one of our Chimes regional networking events, Michigan Regional Roundup. We talked a lot about AI. We talked a lot about the hype, right, and where AI is sort of in the hype cycle. I know you're quite bullish, and you've shared a couple of use cases here where you've been able to apply, yes, technology to help solve some really difficult problems. But give us an idea. What are you really bullish about in terms of AI's potential in healthcare? And then along the same lines, what are you maybe a little hesitant about?
Yeah, I wish we had an hour to talk about this. So bullish, I am absolutely bullish on every dimension here. I think we have now compute at our fingertips, leveraging the public cloud services, the CSPs out there. We have compute locally with new chip packages that are coming out from NVIDIA and Intel and others that allow graphical processing locally. We have the ability now with the intelligence of our records that are digitized of years of data now to pull upon and have a larger N number statistically so we can actually get better predictive analytics going forward. And we have a willing group of operators and clinicians that understand, I think partly due to the pandemic, the power of technology. So they come up with solutions like the trafficking tool. Bullish, I'm going to go on the policy, or on the negative side, I'm going to go on the policy. right now we've got a couple of things that are brewing. You have the HTI-1 rules that were finalized by the Office of National Coordinator, basically saying that if you build an AI algorithm, you have to be transparent about it. Okay, makes sense to me. The HTI-2 rules proposed are now out there, really about interoperability of that data. The drawback in all this is you saw the Supreme Court recently overturn the Chevron case, which really was about overreach of federal agencies. So there's a question mark looming with the executive order around AI, with the rules that are starting to promulgate out there around AI. What's going to happen if a lawsuit comes up challenging the regulatory environment of AI? Do the algorithms that have been built have to be rebuilt? Or do they have to conform to different standards, which could elongate the ability for healthcare to use those algorithms? So long-winded answer is I'm bullish on everything, Keith. The drawback is we're also having to hurry up and wait, which is typical with the federal government. What's going to happen? And of course, the 2024 election will play into that as well. So more to come on there. But net, we should not hold back the progress of solving problems like human trafficking and others because we're worried about what could happen. We should focus on what we control now, make a difference today. And if tomorrow we got to pivot, then by golly, we pivot, but we keep fixing this problem for the good of mankind.
Absolutely well said, Aaron. Unfortunately, we are out of time, and you're right. We could talk for another hour easily about some of these topics. I want to thank you again for getting us started. That was an inspiring and also challenging message. Be bold, right? Be bold out there. We're going to take a short break, but don't go far as we have our first panel session today coming up. That's sponsored by AvaSure, responsible, ethical, and caregiver-centric AI adoption in healthcare. We've got some heavy hitters coming at you for this one too. Terry Couts, Chiro Goswami, Jacob Hansen, they'll all be joining us soon. We'll be right back here at 1:30 p.m. Eastern. We'll take a short break. We'll see you then. Welcome back. If you're just joining us, I'm Keith Friedenberg, Chief Operating and Innovation Officer at Chime. And it's my absolute pleasure to welcome you here today. This virtual innovation summit just wouldn't be possible without the amazing support of our sponsors. So let me just take a moment and thank AvaSure, Microsoft, and Nordic. We greatly appreciate your support. Thank you for helping us bring this virtual innovation summit to life. I'm delighted now to introduce our panelists for this next session on responsible, ethical, and caregiver-centric AI adoption in healthcare. Terry Couts is Vice President and Chief Digital Officer at the Guthrie Clinic. Chiro Goswami is Chief Information and Digital Officer at the University of Wisconsin Health System. And Jacob Hansen is Chief Product Officer at AvaSure. Terry, Chiro, Jacob, thank you for joining us today, and it's great to see you all. Welcome.
Thanks for having us.
Yeah, okay, everybody's off mute. We can hear everybody. Great to see you all. Thanks again for joining us. Okay, time is short in this particular session, all of our sessions today, so we're just going to jump right in. I mentioned in the last session with Aaron Murray that I'm just back from a Michigan regional roundup of Chime members, and we talked a lot about AI. We talked a lot about the hype, but also about the potential. So we're going to kick us off with a question about all the noise you hear out there. AI, everything's AI. What are some common misconceptions you're seeing out in the market today? Terry, can we start with you?
Sure. I think one of the things I hear most often is that AI is going to replace, nurses, or they're going to replace the need of clinical care teams. And I think that is certainly not the truth in the matter. I think, primarily what we're looking at is how do we use AI to enhance or to augment. And we've done that in a couple of different areas, but I think that fear of how does this impact me is certainly out there. I think another misconception is that, there's this concept that the machine or the computer will be making these independent clinical decisions without any kind of human interface. And, that's not what we're aiming for either. I think, it's really just to have some help augment the data to bring it to the forefront, but not necessarily to do it independently. So I think those are the two things that I hear the most that from a clinical standpoint is, top of mind.
Yeah, thanks, Terry. Certainly hear a lot from other Chime members out there, this sort of fear-based response in terms of, oh my gosh, it's going to take my job away. But I also hear often the response that, listen, this is about technology augmenting our workflows and augmenting supporting clinicians, et cetera. So absolutely agree with you on that one. Jacob, can we go to you next?
Yeah.
What are you seeing out there? What misconceptions are you seeing about AI out there?
certainly echo what Terry shared. A lot of questions about how AI can really help somebody work on the right things at the right times, not taking the need for them as an individual away. One other thing I would add is it's an anxiety you have to work around. People, both sometimes caregivers and patients, worrying a lot about being recorded all the time. This notion of privacy. As long as the right steps have been taken, in most cases, this is either live video or live audio, and it's not capturing anything, right? You may not have anything other than a computer-generated image that's live streaming, but there's this anxiety or fear that, hey, PHI or my image as a caregiver is being captured and stored somewhere, and that's really not something that that should limit the benefits that AI can provide. Totally understand the worry. You see this camera in the room and you wonder what it's there for. But certainly a misconception that we run into, this worry about privacy.
And do you think some of that concern is based on just not really understanding the technology or how we're trying to use it in a clinical care setting? Yeah.
I mean, I would say it's interesting. It highlights the importance of training and education. So much of this is just about communication up front to empower people in the bedside or in the unit environments to help them understand, hey, this is what we're trying to accomplish. This is what it's here for. This is what it doesn't do. Information's power in these cases, especially because we ask so much of clinicians anyway. So then you layer on all sorts of new technologies and you just expect them to intuitively understand what it does and why it's there. I think in this case, information's the big equalizer and empowering them on what it does and doesn't do.
Yeah, thanks, Jacob. I want to go to my friend Chiro here next. By the way, I worry more about what this thing is listening to all the time. And the only reason I tolerate it is it tends to help me, right? So I open up a browser and, oh, there's that product I was just talking with my wife about. It's right there in the ad. It's a little creepy at times, but I tolerate it because it's helpful to me. And I think, again, understanding or patients having an understanding and education around what we're trying to do with some of these technologies, I think would mitigate some of that fear. Chiro, my friend, thank you for joining us. How about you? What misconceptions are you seeing out there in the market?
In many ways, Keith, you took my thunder away, because I would say
the
first misconception that, at least in our journey of awareness of AI, I try to remind people that AI did not get invented over Thanksgiving weekend of 2022. AI has actually been around for more than 40, 50 years, actually in the mid-70s, and we have all been using AI for a long time. And if you go through the journey, even in healthcare, we had rules-based logic or deterministic AI, and everybody thinks AI equals generative AI, large language models, and AI equals open AI. When you start with that and you give examples where people have been using AI in their day-to-day examples, and you held up that phone, if you're talking, Siri's listening, Alexa's listening, everyone's listening and sending you alerts. Well, that's some form of AI back in, for about 15 years now. So when you get past that hurdle, then it becomes a little easier to say, all right, now you've got my attention, tell me more about what I need to know. But AI is not new. It's been around for a long time.
And transparency is really key, right? And we'll get into that a little bit more as we dive a little bit deeper into this. We could spend an entire virtual summit on Gen AI. That's not our focus today. We have barely enough time to cover the ground that we want to and need to. We want to focus on AI adoption that's really caregiver centric. So my next question for you all is, how can AI be designed and implemented to better support and enhance the caregiver's role?
From my perspective, we have to understand how the models are being trained, and making sure that we are not creating biases that can perpetuate the ethical concerns that are out there. But I think that there are simple things through automating documentation, ambient listening, computer vision. There are things that are done from a tactical kind of level, from that we add to our clinicians every single day, that can be lifted from that daily burden. And understanding your use case and how you're going to implement that is a big part of our role. But we do have to understand where it's getting its data from, and then how it's being trained, because how my health system provides care is going to be a little bit different than how Churo's health system provides care, and we need to understand that.
Yeah, I have this philosophy about healthcare organizations. If you've seen one hospital or healthcare organizations, you've seen exactly one, right? Every single one is going to be unique. Chiro, I want to go to you next. So let's just imagine you have an opportunity to sit down with an AI technology developer, and you can talk to them about how they can better support and enhance caregivers in the caregiver role. What advice would you offer to an AI developer?
So the call it the four first principles that we always apply is efficiency is a given. If it's not making simple things simpler, don't even talk about it. So the efficiency, the first E is given.
Yeah.
The second one, interestingly, is actually in the title of this presentation, right? Is it ethical? Just because it can be done doesn't mean it should be done. I don't want to use AI to inform somebody that, hey, your loved one got detected positive for a test at 2 o'clock in the morning. No, don't do that. Technology exists for the sake of making things easier, doesn't mean it's always efficient and ethical. The third one is equity. Whether we like it or not, this is a double-edged sword. And if not used appropriately, back to Terry's point here, it will further the digital divide between the organizations, between the large academic medical centers, and where really the heart of America lives in rural areas with small hospitals out there. And of course, also the equity aspect of our population. Some may be privileged and some may be punished by the use of these tools. So we got to be careful of that. And the fourth and probably the most important one from my factor is empathy. Technology should never replace the human being and the human touch that all of us in healthcare signed up to do, is to take care of a patient. And so enable everything in the clinical world, but do not replace empathy with technology. That's
I love that aspect. And I just something that Aaron said in the last session, his keynote really stuck with me, which is caregivers will do just about anything to help the patient, right? And if you can't help them, they'll work around you. And that's how dedicated they are to their craft and delivering great care. Jacob, AvaSure is in this space. You are a developer of AI solutions or AI solutions. How are you looking at caregivers in thinking in terms of how can you better support them in their roles?
Yeah, I really appreciated the sentiments just shared by Terry and Chiro from the health system perspective, and we think a lot the same way. Two things I would add to it is, on our side, when you're going through the design process, a big part of that is also being ultra clear on how you test. And so for us, that means that we have to be super clear that we are finding ways to test in environments that mimic as closely as possible the users that we're targeting, that we're being super clear on what good looks like before we're iterating in production with a health system. And then the second piece to that puzzle is that when we're designing, that we're ultra focused on feedback loops, iterative feedback loops. We have to have ways for clinical leadership, for users, for our teams to all stay connected and engaged, because every environment is different. That means, right, doesn't matter what kind of AI you're talking about, in most cases, you've got to make sure that it's getting customized and learning in the right way. So the only way that you can do that is if you've established these loops, whether it's in the design of the system or process to match it, to make sure that information about the performance and behavior of that artificial intelligence has a way of being measured and then adapted as you learn.
Yeah. Terry, you mentioned something in your response to the last question about ethical concerns. What are some of the primary ethical concerns you and your organization are worried about when you're integrating AI into virtual care settings?
Yeah, a couple of these. Did you say Terry or Chiro?
Terry, sorry.
Okay,
Terry.
sorry. A couple of these things have already been mentioned already. The privacy concern, and it's not just about the cameras, right? I do believe that there is a responsibility that we have to make sure that we understand the data collection, where it's being stored, how it's being aggregated, whether or not images are stored and those things, and making sure that the patients get the privacy that they deserve. Obviously, we had the same kind of concerns when we implemented our virtual nursing program, not just from a privacy of patients, but also privacy of caregivers. And so they were also concerned that there was this big brother kind of concept that we were auditing them. And so really making sure that we address those privacy and data security concerns. I think also, just transparency on how the AI works and the algorithms that are being implemented to help make the decisions. I think, we have, as leaders, have the responsibility to understand how it was trained, where it was trained, be part of that training, kind of like what Jacob was talking about. We have taken the approach that we're actually training in our ecosystem because, way our rooms look, the way that our devices that we use are going to be completely different than another health system because there's many different choices out there. So we have to understand what those algorithms look like and where the data, and then consistently validate. Just because an algorithm works now doesn't mean that there's not something that's changed in our environment, and that we have to have a way to validate that those algorithms are still safe and appropriate for use.
Yeah, thanks, Terry. Chura, I want to go to you next. I want to mention a conversation I was a part of late last week. We were talking about transparency in physician-patient communication. We, of course, now have the tools that allow AI to draft a communication from a physician, right? If you're doing this right, you're being transparent. The physician has to review it and then okay it, right? And then you send the communication. And you see examples where at the bottom of the communication, it might indicate to the patient receiving this that, hey, a part of this communication was drafted using AI. And the question was, as a consumer, how does that make you feel? And I was a little mixed, and we'll go to you on this ethical question here, but I was a little mixed in terms of my response. From one perspective, the transparency is key, right? As a consumer, I want to know that my physician is being transparent about the fact that they're using AI. On the other hand, I was asked, do you trust the communication more or less because AI helped develop? I said less, but I don't know why. My brain had a hard time sort of reconciling that. I don't know why I feel like I would trust it less. I use Gen AI every day in my work, right? So I'm trying to embrace it from a consumer perspective, but it gets back to issues around transparency. Chiro, all right, to you. What are some of the ethical concerns? Probably a lot of them are very similar to Terry's, but are there other concerns specifically at UW Health?
Absolutely. I mean, Terry said it very well. All of us are involved in conversations about the local data validation versus the national assurance labs and things like that. And Terry's patient base is very different than mine. So what works in New Jersey doesn't work in Wisconsin,
right.
so to speak. And it's very important to know that. I would also go back to the transparency. We had a lot of conversation internally, and all of you know me well where I stand on transparency. In that case, knowing that what Keith thinks, it's only for Keith, and Jacob may have a very different interpretation as you laid that out. We actually did not put that footnote, and our rationale for that was the human is accountable and responsible for the final acknowledgement of the message. And our concern was the day we start doing that, not today, but 5 years from now, when it works 99.9% of the time, the human will absolve himself or herself from the responsibility and basically blame the technology when it doesn't work. So I don't know what we're going to do 5 years from now, but we took that hard step of using the rationale to do that, and further not confusing the patient in the example that you shared in your own words. Now, for ambient listening, 100% of the times we will ask for consent before we start the interaction with the patient. So it's a little bit, actually, Keith, going back to misconceptions, it really comes back to the consumer base does not have a common understanding of this technology. And healthcare is an industry where your consumer is coming to you when they're already stressed. Yeah. Let's not stress them further. Let's take care of them. That was our approach in going through it. Our last part of ethics actually comes back to our vendor partners, right? Data is data, technology is technology. We are holding the bar high for our vendor partners in being transparent to us, Because once it's in the cloud, I cannot tell you what to do with my data. You can start using it and coming back and incorporate AI in your process. So we are raising this question right now for some of our RFPs and stuff to say, how do you plan to use the data? State us your principles of acceptance, your principles of endorsing this technology. And that's the way we're saying it's a community that's going to hold up to the high bar, not the low bar that breaks the rules out here. That's that to Terry's comments.
Yeah, really well said. Jacob, I want to go to you. I think that's a perfect setup. So how does AvaSure manage these concerns, and how do you work with organizations like CIOs and Terry's in terms of understanding their ethical issues, but also being reactive and proactive and responsive to them?
Yeah, well, first I'd say, Chiro, you're not alone. I would say in just about every RFP we see now, there are elements of how, what forms of AI you use, how you measure accuracy, what data do you capture, where is it stored, all of those types of things. And privacy and bias are really sort of the top of mind ones that come out, especially under the collective AI umbrella. But the more specific you get about the type of AI you're deploying, then the more targeted you can be around ethical concerns. So for us, our focus on AI tends to sit more in the computer vision and ambient listening side. And when you think about those two, then all of a sudden safety becomes an ethical concern. And I think Terry actually mentioned this, that people are able to trust. The whole purpose of AI in those two use cases, in many ways, tie to human beings that are trusting either augmented alerts or the ability to take care of more people, or just the technology in general. People have to trust that it does what we say it will do. And that means that kind of comes back to this notion of staying aligned with our partner customers, health systems, to make sure that we're bringing something to the table that's been thoroughly tested, that we have clarity on how we will stay connected. The safety of caregivers and the way that they support patients has to be at the center of every single thing a health tech vendor does, or we're not living up to the standard that our customers need.
Yeah, really well said. Jacob, for the next question, I want to stay with you here for a moment. I want to talk about use cases or examples where you've witnessed where the technology has positively impacted caregivers, whether it's making the workflows more efficient or improving patient engagement or interactions. I've read some of your use cases, AvaSure's use cases. Would you be willing to share an example where you've got a really great example here where you have positively impacted caregivers?
Yeah, I would say our primary focus when we started down this path was really aimed heavily on the safety side of things. So falls and elopement in particular. So that's a big case where we've put our focus, where we're empowering virtual safety attendants and observers to really stay keenly connected to patients, to catch things above and beyond just what they're watching for, because the augmentation that AI provides can put them in a position to succeed. And all of that obviously requires clarity around the why. Hey, what benefit do we expect this to create for you, the caregiver? And then with that clarity, an ability to evaluate how well it's doing that. So there's really the two lenses there, especially whether it's falls or elopement or self-harm, that in all those cases, we are creating positive outcomes for the patient, but also that we're facilitating better outcomes for the caregiver as well. Those are some of the ones that we started with and that we're excited about the benefits that we've seen.
Yeah, thanks very much, Jacob. Cheryl, can we go to you next in terms of any technologies or tools you've adopted that have demonstrably improved caregiver roles or workflows or patient interactions?
So some of them are in the works. I wouldn't say demonstrably, but we're on the journey from good to great, if you may, on that. So again, 15 months ago, we were among the first in the country to do these in-basket message response generation. At last count, we have over 125 members of care teams, not just physicians, but also nurses. We forget about the largest workforce, it's the nurses. And Sherry's smiling because I know she's one of them.
We have one right here.
And so we took the approach of working with them and again, reducing the time that they don't have to start with, spending all those. We are in some early test cases of note summation at shift change for inpatient nursing. That's a use case we're working through. Obviously, ambient across the board. I think many health systems are already on that journey. We're there. I know this part is focused on clinical, but I would be remiss if we don't bring out that there's tons of opportunities for non-clinical utilization of AI tools, which actually still steals from the 168 hours we all have every week, like contracts management, PowerPoint generation. These are things that it's the tax we pay, on nights and weekends working on this. And so by generating some of that work through AI, we're giving time back to people that they can then focus on true clinical care.
Yeah, I know we talk a lot about pajama time for physicians and clinicians, but how many of us here also have pajama time? All of us is my guess. So Terry, let's go to you. You are a nurse by background and training, and so some of this is probably really near and dear to you in terms of some of the things you're doing at the Guthrie Clinic to really help the lives of our caregivers and clinicians. Can you talk about an implementation or maybe a pilot program that you're really bullish about, that you're seeing some real positive improvements?
Yeah, so we have done a lot of work with nursing. The pandemic hit us hard towards the end of the pandemic, and we had an exodus. We paid a ton of money to travelers. We had quality go down, and we had issues with unexperienced nurses taking critical care patients. And so we put a large emphasis around how do we augment their care to increase to affect all of these. And we have done this through virtual nursing platforms and through some automatic documentation, through some escalation algorithms in this platform that helps us have virtual nurses see an escalated need for care, help a nurse that is not necessarily experienced in care, particularly if they were trained during COVID time, because they had a different experience than most nurses that come out of nursing school, and just being able to support them. And what we've found is that not only the automatic documentation is helpful, but the ability to have support, to be able to call out. We've been able to decrease all of our travelers in our ICUs, actually, which was about a $7 million savings, but also just being able to support that care. So it impacts our hospital-acquired infections. It impacts the ability to care for our patients differently. I think that is monumental. It's not just AI, but it's technology enhanced with AI. And also kind of building off of what Chiro said, I would be remiss, because we've gone through a recent cyber event through a hospital that we acquired. Our SOC uses AI, our Security Operations Center, as a primary tool that keeps us safe every day.
Yeah.
And our caregivers safe. And it's unfortunate in the situation that we have in healthcare today that we're being attacked the way we are, but that's the truth of the matter. And so, I think that particular use case not only impacts his patients, but also our caregivers.
Yeah, absolutely. We've got AI augmented cybersecurity tools out there that do automatic endpoint detection and response, and it can do it in milliseconds, right? Faster than a team member in a SOC might be able to recognize it and send an email alert to somebody else saying, hey, we may have an issue here. That's some really cool stuff. I think what terrifies me, and I know this session isn't about cybersecurity, but I'm glad you threw that in there, because it is the tax that we pay, Chiro, right? We're paying a cyber tax, a cybersecurity tax. Every healthcare organization is. What terrifies me in this space is that the really bad actors out there also have their hands on some of these tools as well, right? So it's constantly a game of you got to one up because they're one upping. It's terrifying. Just time for, I think, a couple more questions. So looking out into the future, I mean, AI didn't start on November of 2022, right? It's not the dawn of AI. It's been around a lot longer than that, but it is accelerating since the dawn of Gen AI. I think we would all agree. Thinking about some of the most promising technologies that you're seeing out there that you're excited about. Maybe you're not working with them today, but you've got your eye on this technology, or you're seeing developments that have you feeling really bullish on something. What are you seeing out there that's got you excited in terms of an opportunity to really improve patient outcomes in virtual care?
I'm happy to jump
Jacob,
in
please.
first
Jump on in.
if nobody else wants to. I'll tell you some of the things that we're actively working on that we're really excited about. Many of them tie to ambient listening, and right, for us as a health tech vendor that's hybrid hardware and software, we're always looking for ways to create more benefit for our customers using the technology in the room. And so from an ambient listening standpoint, one that we care a lot about, that we're super excited about, is staff duress. And so the ability to use those large language models that Chiro referenced to monitor any risk of violence to a caregiver in the room. Super excited about what that can mean for caregivers. They can trust that there's something listening and paying attention to what's happening in the room, listening for specific things to indicate the likelihood of violence. We're super excited about that. And then on the same side of that, just the benefits that can be created to staff in a variety of ways through things like wake words and digital documentation. We're just really excited about what the power of ambient listening can mean alongside computer vision things that we've already launched. And so we're really looking forward to bringing those to the market.
Thank you, Jacob. Chiro, Terry, we've got about 60 seconds left, but I want to give you an opportunity to also share your thoughts. What are you excited about? What do you see out in the market that's got you excited about? Chiro, please.
At this point in my career, technology doesn't jazz me. It's the adoption of technology that excites me. And for the first time, I have hope in my lifetime, we will be able to remove the computer between the patient and the provider in an inpatient setting. All the technologies that we talked about.
I love that. I love that vision. Okay, Terry, last thoughts.
I would echo both Jacob and Chiro, but I would add that, I do think that we're at this influx of AI where we can actually provide the right care at the right time with the right data in any care location. And so that really means that you don't have to come to the four walls of the hospital. How do we use this technology to make sure that we're providing the care at the right time? And I do think that we're in that influx with the right processes and adoption that we can get there.
Well, I want to thank all three of you, Terry Couch, Chiro Goswami, Jacob Hansen, AvaSure, our session sponsors. Thank you for all you're doing every day to improve patient care, to support our caregivers out there. Thank you for that. We're going to take a short break, but don't go far. We'll be right back here to introduce our next panel session, sponsored by Microsoft and Nordic. We're going to talk about AI and AI innovation, but not only AI and AI innovation. We're going to talk about other paths to innovation as well. With all the hype surrounding AI, it's easy to lose sight. There are many paths to innovate in healthcare. So join us right back here at 2:05 p.m. Eastern. We'll kick things off with our next panel session. We'll be right back here. We'll take a short break. See you soon. Welcome back. If you're just joining us, I'm Keith Friedenberg, Chief Operating and Innovation Officer at Chime. And it's my pleasure to welcome you to the Chime Innovation Virtual Summit. This program is made possible with the tremendous support of our sponsors, AvaSure, Microsoft, and Nordic, and we want to thank them for their generosity. I'm delighted to introduce our next session and our panelists for this upcoming session titled AI, Not the Only Path to Innovation. We have Dr. Engers Fernandez joining us. He's Vice President for Innovation at Ocean. Jason Griffin is Managing Director, Digital Health Strategy and Cyber Practice with Nordic Consulting. And Laura Kriowski is the Rural Health Program Lead with Microsoft Tech for Social Impact. In this session, we're going to focus on the numerous other paths to innovation in patient care services and business operations, not named AI, although we may also talk a little bit about AI. We've got a great panel of experienced leaders with us, and I know they're eager to get this conversation started. So let's go ahead and jump right in. Laura, Dr. Fernandez, and Jason has not been able to join us yet, but we're hopeful that he can join us. So Laura, Dr. Fernandez, welcome, and thank you for joining us here today.
Yeah, thank you, Keith. It's a pleasure.
All right.
Only a pleasure.
It's great to have you. Our time is short, and we want Jason to join us. And I know the team behind the scenes is working to get him on here. But we are time constrained. So if it's okay with you, we're just going to jump right in.
That works for me. Yes.
Okay. All right. Excellent. Well, I said we're going to talk about innovation that's not related to AI, but we're also going to talk a little bit about AI. We've been doing that for the past hour plus. And listen, the two biggest topics out there in the healthcare industry are probably AI and cybersecurity. We know there's an abundance of hype and hope around AI, as well as many ethical and governance and bias and transparency related issues. So we talked about those just in the last session. As you all work for very different organizations and unique care delivery organizations, how are you seeing this playing out within your ecosystem? Is there more hype or more hope? Which are you seeing? Dr. Fernandez, let's start with you. More hype or more hope?
Okay. Well, I think, and I've been thinking a lot about this, and I will give my answer in the shortest amount of time. Because there are two drivers, right? That is increasing the hype and the hope. The main driver has been end users. Just recently, I think April or May, Microsoft Workforce Trend report shows that 75% of knowledge workers are utilizing what is called bring your own AI to work.
Ooh,
so that's
that terrifies digital health leaders.
That's shadow AI at its best, right? And regardless of the generation, obviously Gen Zs is really high, about 86, 89%, but
Wow.
also boomers is about 65%. So everyone is using it in the middle. Now, we acknowledge this really early at Ocean, and what we did was making sure that every single Oceanites, we call our staff Oceanites, was aware that we know this is happening. And as it's happening, we provided guidance on how, if you do it, this is the way to do it. De-identify any information regardless to the business that speak directly to the business. And we gave each one of them like how to use it. Provide prompts, because anyway, if they're using it, they use it right? Let's get what we're supposed to. So provide a few prompts and prompt classes, and then teaching AI as a whole, right? Because generative AI is not the only AI. It's the one creating the hype, but it's not the only one existing in the market.
Exactly.
And then from the other side, organizational side, and I go really fast, this is what we did. Number one, make sure all your executives are in line and design a set of AI principles on how it will be implemented. Number two, there are different frameworks, and I know Laura definitely is going to talk about train and shy everything that they're doing, so I'm not going to talk about that. But the one that we decided to do was FAVES, and FAV as in Victor ES, for those that want to check it. Then with that framework, we design, we call it Radar, which is an assessment tool for each one of those AI tools that are coming in, especially generative AI, that is mapped against our framework and against our principles, and then design an inventory. That now we're seeing as the federal regulations are coming out and state regulation, that was the right path, because we can track back why we decided to implement which tool and how. So that's what we have done. And Laura, I'm going to pass it to you because I don't want to take over that conversation.
Thanks very much. Laura, what are your thoughts?
Well, as you know, Keith, I recently joined Microsoft as the leader for the Rural Health Program as part of Microsoft Tech for Social Impact. And I have to tell you, it has been such a learning and such an exciting experience, because Microsoft clearly is invested very heavily in this. They really see this as sort of the next generation, if you will, of digital innovation is AI. Everyone from the CIO down, and the CEO down, and if you follow the news in the Wall Street Journal and the New York Times and things, you clearly see that that's the direction organizationally we're headed. We also understand we have an immense responsibility here as one of the leaders. And so at Microsoft, we have a whole team dedicated to responsible AI. Even within the team I work for, the technology for social impact, the Tech for Social Impact team. We have a team called AI for Good. We have a responsible AI champ that is, as we deploy new Gen AI solutions out to the market, it has to be vetted by that individual. And as Engers mentioned, Microsoft is very involved in TRAIN, which is the ethical AI initiative across healthcare, with about 40 marquee organizations participating, and to really set that framework about not only how do you define ethical AI, how do you operationalize it?
Yeah.
So I would say from our organizational standpoint, there's a lot of hope and a lot of hype. I'll also then just real quickly say at the rural hospital level, where I'm operating and working really hands-on with these organizations, I think there's, they're watching and waiting, and they're also at the same time wading, WAIDING, into this space. So I think we're going to see a large uptick in that space.
Yeah, thanks very much for that. In my role at Chime, I have an opportunity to speak with Chime members and digital health leaders on a daily basis. It's okay, by the way, to not be at the forefront of the AI bleeding edge today, right?
Yes.
In fact, a lot of organizations are being very thoughtful about the fact that they're letting others go first, right? And they're learning. We'll be a fast follower if that's what we have to do behind. And a lot of that is resource driven. Laura, I know this program isn't about cybersecurity, but I'd be remiss if I didn't know the work that you are supporting behind the scenes that's related to Microsoft's support of rural hospitals and healthcare organizations, and providing them with some of the tools they desperately need to fight back on this cybersecurity arms race. So I just want to mention that. Thank you for that work that you're doing. Again, it's completely unrelated to AI in this topic today, but I just wanted to say thank you for that work.
You're so welcome. It is an honor to serve those hospitals. I'll tell you what, right? To bring something that's so badly needed and give them the resources and the tools to help fight data breaches. So thank you, Keith.
Yeah. I speak with rural healthcare leaders all the time, and oftentimes what they tell me is, Keith, I'd love to be in this AI game. I don't have the resources for it. Every resource I have is aimed at cybersecurity and protecting my organization. It's AI is a nice to have. It's not a need to have. So anyway, applaud that work. Dr. Fernandez, back to you. AI is coming at us from everywhere. Laura mentioned CEOs, and so this is what people like you are seeing, right? The CEO seems the cool tech. The CFO, the CMO, the CNO, it's coming at you from everywhere. Are you seeing that AI is starting to suck up resources and support away from non-AI related technology platforms, implementations, projects, initiatives, et cetera? Is it pulling resources away?
Well, in our experience at Ocean being a nonprofit, we are very protective of the resources that we have available. So one of the challenges actually for me has been, hey, can I get a little more resources here in this side that is creating a lot of noise? Our business model is basically providing services to our members, and the members themselves, they are asking, because with the hype, it comes just the marketing side, just saying this is gonna decrease the burnout of your providers by 15%. We CEO doesn't want to do that, right? In this time and age. But in order to do it in a safety manner, we need to bring resources that have the ability to understand the technology, assess the technology, and do all those processes that I was talking about earlier. So yes, it's eating up, but I think one of the things, especially in the nonprofit, FQAC, rural health perspective, there is an understanding of we will introduce the technology, because it is helpful, but we would do it in a very responsible manner. So that's one. The second piece is the skill set is not there yet.
Yeah.
So inspiring internally staff to get better at the skill set is one thing that we have put as priority. I have leveraged a lot of the documentation that Microsoft has designed, because Microsoft has put a lot of tools out there to make sure that if the technology will be used in a trustworthy and ethical manner. Now, it's bringing a lot of fights internally, and when I mean fights, not actual physical fights, right? It's just where our attention should go. But we have a lot of fundamentals needs that haven't been solved from before generative AI come and make that noise, that we have to put a lot of intention. So how we have going to prioritize that, I think that's a piece of information will be helpful, is assimilating tools one step at a time. Not tools, features one step at a time. We have been putting a lot of energy in those that will be impacting providers burnout, and those that will enhance somehow patient access. Those are focus number one, which is in line with our mission and what we're trying to do. So, and the guidelines for that prioritization comes from those set of principles that I spoke in the beginning.
Yeah.
That although in the beginning might seem like, oh, you know, it might be a waste of time to not negotiate those, because they become the path on what will come in and out.
Yeah, sort of your non-negotiable tenets. Laura, I want to move to you for this next question. We heard in the last session from Shiro Goswami. He said, Keith, look, AI didn't start on Thanksgiving Day 2022. Okay, maybe the Gen AI started, but AI has been around for decades, right? That being said, Laura, how do we strike the right balance in terms of advancing AI while also continuing to focus on human-driven and innovation across the healthcare enterprise? Because at the end of the day, there's technology, there's people in process, and it's easy to get caught up in the hype of AI and forget about what's actually behind all of this, which are people, humans. So how do we balance that?
Yeah, Keith, excellent question. And I think this is one we all have to be immensely attuned to. When Angers and I were preparing for this, he said something that really has resonated with me. And he really said, all innovation is not technology, all technology is not innovation, right? And I think we need to keep that in mind. What I think is really essential here is that we listen. We listen to the voice of the customer, and listen, what are the constituents telling us within the organizations? What are their pain points? What are their suggestions? At the end of the day, that's where the source of innovation can and should come from. And so while some of that can be enhanced or enabled by AI, it's really, organizational specific and comes down to listening and responding. Now, we can't meet everybody's needs, and we can't meet everybody's needs with AI. But at the end of the day, if we're not focusing on what's driven by the stakeholders inside and outside the environment, we're going to lose sight of the fundamentals here.
Yeah, thanks, Laura. Dr. Fernandez, thoughts on that? How do we continue to strike that balance, advancing AI, but also realizing that at the end of the day, people are really in the middle of all of this?
Laura and I have a lot of conversations, so I'm glad that we get to be here at the same time. And among those conversations, also one thing that my role is vice president of innovation. So most people look at innovation and think everything that is cool, everything that is coming forward, so on and so forth, right? But it's totally a little more conservative than that. And I will be the first one probably fighting what I'm about to say, but it's true. This is the pragmatic truth, is that the way I tend to look at innovation is thinking 5 years from today, 3 years from today, 10 years from today, what it will be constant. What are the needs that with consistency we know we need to meet? In our cases, there's always going to be a patient with a need to see a doctor, and there will be a provider. That's the center. That's the cell of the entire healthcare system. When we look at from that perspective, there are many needs that not yet has been met, especially in the EHR world, right? Like the promise, probably some people have forgotten, when EHR came to our world, the promises were very high, and there was a lot of hype. And now we're dealing still 20 years later with many of those challenges. So the right balance will be, to answer the question directly, is make sure that you understand what is going to be constant in your, not just in the industry, but in your organization, and then put the energy there. There is a really good thing though with generative AI, that because of the capacity of this godlike type of technology, it can enhance many of those fundamental needs. But there are many, this generative AI, as in moving from just moving from large language model to a smaller model that are more specific into the needs. I think that both things can be managed as long as you have someone that understand the technology and understand the need of the organization and where the organization is going.
Yeah. We're both innovators, so I'll share a quick story with you from a good friend of mine, an amazing innovator, Todd Dunn. He shared with me once at a chamber, he said, Keith, you have to recognize when we talk about innovation, most people think we're building rocket ships.
Yes.
Okay? The rocket ships that go to the moon. The reality is it's never that sexy, right?
Yes.
It's really more about often improving workflows and efficiencies. It's the constants in how do we do it better, cheaper, faster, higher quality, etc. It's not flashy. It's not always the funnest innovation, right? It's not building rocket ships, but it's important nonetheless. So we've talked a lot today about AI, and I'll say this, not everything is puppies and sunshine. There are real concerns. There are concerns about transparency and ethical concerns, and how do we adopt and embrace it responsibly? So how do we now strike that balance between innovation and caution, ensuring that if we're adopting, utilizing AI, or even non-AI technologies, that we're using those tools to enhance patient care without compromising ethical standards and being responsible about what we're doing? How do we strike that balance between innovation and caution? Laura, do you want to start first?
Yeah, I mean, I think there's a couple levels. One is at the global sort of industry level, and then one is just more tactical in the organization. And I'll share an example of an initiative we're working on that I think really addresses that latter scenario. Most of the industry is familiar with CHAI, which is really CHAI, which is really working to set some basic guiding principles, rules of the road, right, and for the healthcare industry. And then its counterpart is TRAIN, which I mentioned earlier, and it's a coalition of about 40 healthcare organizations, and actually has been really embraced overseas and internationally. And I could see this really gaining momentum. But their role is, how do we operationalize this, right? And how do you do it in a way that strikes speed to value and that caution and that prudence, pragmatism you talked about, Keith? So I think that's where we need to work as an industry together towards that sort of, it's not going to be perfect. It's not going to be right for everybody, but if we can start coalescing and learning and sharing, I think there's a lot of value in that. I also think it needs to happen at the organizational level. And I think this is a little bit of a challenge, and I'm glad you, Keith, mentioned the rocket ship example, because so much of our work is not building rocket ships. It's like moving piles of dirt around every day. It gets a little better every time you move the pile of dirt.
Right? I'll clap to that also. Yes, moving piles of dirt.
Yeah. And, we've talked a little bit about this, and Angers and I, we do chat a lot. And I think one of the areas that will benefit so much from innovation and AI, Gen AI driven innovation is the FQHC and the rural health space. Yeah. So we have to do all we can to promote and enable adoption. And one of the initiatives Angers and I and a handful of rural hospitals are involved in is a program that we launched in parallel with all of our cyber work around generative AI for hospitals. And it was this for rural hospitals. Again, this concept of let's bring some stakeholders together and listen to what their pain points are and come up with a lightweight, no-code Gen AI tool that solves one of their unique struggles. And so we did this. We had a workshop. We had 2 days. We talked about AI. We talked about, the fears and concerns it brings to the organization. And then we started talking about use cases. And what we did after we defined our use case, we actually took those 5 hospitals and those CIOs and their revenue cycle leaders through a development process of about 6 to 8 weeks. And we showed them how algorithms got created. We showed them, we got their input on the algorithms and the validity, and now they're doing the testing. And, you can't do this for every hospital with every AI product, but what we did is we broke through that barrier of understanding. We went from, the robot's going to take my job to this is really cool, and here's its strengths and limitations. So I think it's tremendous education that needs to happen.
Yeah,
Yes.
you remove the fear, right? You
Yes.
remove the fear about the technology. Dr.
Yeah.
Fernandez, your thoughts?
Yes, I know we're short of time, so everything she said is right on point. And then the only piece I'm gonna build upon is the ethic view is for humans. The tool is doing exactly what it's supposed to do. It's doing it. And we need to understand they're just gonna get better at it.
Yeah.
Now, from our side, from the ethical point of view, that is from the human side, it is understanding. And since this forum is for innovative executive, I make a call out to you. Make sure that your CEO, that your COO, that your CFO, they have even the fundamental understanding of what the technology is, where the limitations are, and where the power is. You as a CIO, CTO understand it's not going to be enough. One, I keep saying, I tell this to Laura a lot. One is too small to create a real impact. So it's not going to be just one organization. It's not going to be just one industry or one nation. It has to be global and understanding global from the ethical standpoint on how we move forward. So bottom line, everything she has said, but build on top that the education is not just for the staff that are using it on a daily basis. Our decision-making process, it has to be also really well educated and not spending the time today to understand the impact that these innovations are going to bring in, not just in our industry, but the communities that we serve. I'm going to put it in a more basic way. We cannot treat this type of technology the same way we implemented previous technology. That's not going to play out. We need a new playbook, and that playbook is being in the making right now. So we need to come together. This is one of the greatest things that I see Shai is doing, Train is doing, Rel is doing, the program that Laura was just mentioning. But we need more. We don't need less. We need more education that is not limited just for those that are technology fans or technology driven in our education.
Yeah, Dr. Fernandez, you just touched on the core philosophy that Aaron Murray shared when he kicked off his opening keynote, which is what worked before will not work now.
Yes.
It doesn't work in this accelerated AI healthcare environment in the journey that we're on now. And you're right. There's no playbook for all of this. We're writing it now, right? The playbook is being written now. And if you look at how things are accelerating just from March of this year, 90 days later, right? We're talking about AI in ways we didn't even consider 90 days ago.
Yes,
right? So
that's true.
Old rules will not work for a new game is absolutely what we're talking about. The two of you have really emphasized the need for education or educating users as well as transparency, right? To build trust and build confidence, reduce fear. Are there other practical strategies that you could share with others who are with us here today, listening in, that you're using at your own organization, again, to improve trust and confidence, reduce that fear?
Yeah,
Laura?
Keith, I have a couple ideas, both based on my work at Microsoft and also in previous roles. And really, I think importantly, in the work I've done in the safety net with FQHCs and community service providers, is that organizationally and even as an industry, we need to think not just about clinical applications, which are profound, that they're very complicated, right? And they touch on a lot of ethical things. There's a lot that can be solved at the business level, at the care management, transfers of care with AI. And I think when we think about an ecosystem of care being healthcare, communities, social services, organizationally leaning into that. I think that's the first part. I think the second thing is, right, AI is the it right now. It's the it thing.
Yes.
But as the title of this session implies, let's not lose sight of why we're here and who are the real experts in the room in terms of innovation. And so often that's that frontline staff, and listening and tuning in and supporting them.
Well said.
Yeah. I just going to add to what Laura said. The number one practice that is important besides getting educated is understanding that many of the drivers, especially in the healthcare field, that will be impactful are not coming directly from the healthcare field itself, from the processes that we have in place. They're coming from parallel sites, folks trying different tools and then bringing to their own. One of my biggest fear, honestly, but also it is one that I'm really excited about, is that this technology are coming together, is increasing and facilitating the access and understanding of care to the patient itself. But that makes them also very vulnerable.
Yeah.
And our standard of practice will not work in 3 years, 5 years from today, because the models that are coming out and that they're playing on their phone and they're looking at it. I have a headache. I cannot see my doctor. Probably the next appointment is just in 2 months. I need to have something today that will clarify that to me. Where are they going to go? To that gadlight technology that they think is the solution for everything. So we have to look outside of the framework that we have to design for ourselves and get connected, not just with the front, but the real client for healthcare, which is the patient. Yeah, we have to get closer to that area than we are today.
You're going to spin me up, and I'd love to spend another hour with you talking about consumerism and patient access. And but we're quickly running out of time. I'm sorry to say, we've got about a minute left. I think it's safe to say the three of us are bullish on innovation in health and care today, and I think the opportunity for AI and even non-AI tools to support and augment that innovation. Looking out a little over the horizon, what significant innovation in healthcare delivery do you see the next 1 to 3 years? Understanding that 1 year seems so far out right now, but the way things are accelerating, 1 to 3 years, what do you see? What's your vision for the future here?
Laura, I'll go first because I tend to talk a lot, so I want to make sure your voice is in.
Yep, no, I'll just be quick. I think we're working our way through the honeymoon stage here, right? And it's kind of happening at warp speed as we've talked about. For me, what I think is really most intriguing and what I think is most valuable, and where we're going to hopefully see, a lot of innovation and change, is what I mentioned earlier, is that using technology, using innovation in many forms to bridge and bind health, social services, substance abuse, behavioral health, these historically disparate silos that are literally, killing our many individuals and hurting communities, using innovation to improve the care of those individuals and those communities.
Thanks very much, Laura. Dr. Hernandez, 30 seconds or less, your vision for the future.
30 seconds or less. This large model, they're going to become smaller, very driven in a specialty. We're going to start seeing agents coming this at the end of this year, beginning of 2025. And if you combine those trends with our push of value-based care, here's a term that I'm start reading now, is results as a service. Value-based care is going to turn to results as a service for patients, for providers and organization. And I can see you already, Reed, saying that's going to be a tough one, but I think that's the path where all the trends are marked. That's kind of the path that we're seeing flag. If you want to go 5 years from today, my prediction is that brace yourself with this concept of agents. I can see providers managing different type of bots that are patient facing, and that decreasing hopefully the burnout, but also increasing access to patient from a source of information that is reliable.
Thank you. On that note, I want to thank you both, Dr. Engers Fernandez, Laura Kuriowski. You've both been a lot of fun. Thank you for joining us today. I wish we had more time, but unfortunately we are out of time. I want to thank Microsoft and Nordic for supporting this particular session. We're sorry Jason Griffin wasn't able to join us. Jason, we hope everything's okay. You're doing well. We're going to take a short break here. Don't go far. We're introducing our closing keynote speaker and a good friend of mine, Atul Kanvinde, CIO at the Shepherd Center. For our next session, from AI and cybersecurity to virtual care, customer experience, our closing keynote, we'll explore the crucial role of CIOs and digital health leaders in shaping the future of healthcare. You'll discover why fresh perspectives are the key to transforming health and care services, and why thinking differently is an absolute requirement for today's digital health leaders. Don't miss this one. We'll be right back here at 2:40 p.m. Eastern. We'll take a short break. We'll see you soon. Welcome back one more time. I'm Keith Friedenberg, Chief Operating and Innovation Officer at Chime. It's my absolute pleasure to welcome you to the Chime Innovation Virtual Summit. If you're just joining us for our final session of the summit, I want to again say thank you to our program sponsors, AvaSure, Microsoft, and Nordic, for their tremendous support. We appreciate you. You helped us make all of this happen. It's my absolute pleasure to introduce our closing keynote speaker and friend of mine, Atul Kanvinde, who is the Chief Information Officer at the Shepherd Center. From AI and cybersecurity to virtual care, customer experience, and engagement, Atul is no stranger to thinking differently, and more important, doing differently. Buckle up for the next 20 minutes as we explore the crucial role of CIOs and other digital health leaders in shaping the future of health and care. We're going to learn why fresh perspectives are really the key to transforming health and care services, and more importantly, why thinking differently is an absolute requirement for today's digital health leaders. With that, Atul, my friend, welcome, and thank you for joining us to close out the Virtual Innovation Summit today.
Thank you, Keith, for your kind words. Good afternoon. Sound check. You can see and hear me okay? Good.
We're good.
Thank you. I almost felt after listening to the panelists that I do not have to do this in the keynote at all, because they covered pretty much the key points we want to all do. But since I have the time, I'm going to share my opinions and thoughts, and hopefully they jive and connect with all of you. Before I do that, the only slide I have on AI is the following slide. One is connected to an HBR article that came up, but this is very important to me, and I hope this makes sense to all of you, is to look at AI not as technology. Look at AI as a fellow employee, fellow coworker who is so smart, you want to hire him or her, but does not have some of the skills you want to transform on the conversation, so to speak, the personal skills. So that changes the mindset, because I'm not looking at it as technology, but as an enabler, as a co-pilot, no branding here, or a friend, a scribe. And the second thing is on the topic of what happened in fall 2022. You're right, AI is not new to the land, but it made that available into the hands of a layperson. And the layperson is an average analyst, or it could be the CEO who says, I want that. And it's no longer behind the curtain of IT leaders or IT folks who say, I'll give the report to you tomorrow. Well, I can do this myself. So I put myself in a different way. But before I continue, let me tell a story. So I work with Shepherd Center. I'm the CIO of Shepherd. And the Shepherd Center is a long-term care hospital, and we are in the rehab business, so to speak. So here's the context. A patient in the day program had a goal of greater independence managing their wheelchair, something they will be using forever. One of the items on the wheelchair is a lateral thigh guard. Remember, the patient has no finger function. I cannot shake hands with the person. There is no grip. They only hold their hand this way. So thinking differently, this person who is part of the assistive technology group, who is also an engineer, designed a rubber handle and a funnel guide to make this possible. This was done in-house using 3D printing, and this is how it looks like. This is the chair on the left side, which is the thigh guard, and this is how the setup is. If you follow what I'm doing here, you can see how the hand, which has no finger function, it is just in the position, and all the person in this case is doing is moving the fingers in that slot and lifting it forward. The things that was done differently as a design are the two things that I highlight, which were made from plastic and rubber and built in-house in a 3D printer. I say this because it changes my perspective on what different is. About me, this slide is not to tell about myself, but the point is I'm not a clinician. I'm not your typical infrastructure technologist, but I'm an engineer. I am a manufacturing process engineer. I've done industrial engineering. I worked in multiple different hospital systems, from acute care adult to children's to now long-term care. I've been in a software company building software for Fortune 100 companies. I've done all of those things, and I'm not from this hemisphere. So I bring in a different perspective. So I posted this question a few months back on LinkedIn, and I want this group to just follow along. How many of the health systems decide going one way because of a Me Too syndrome, the fear of missing out, so to speak? How many of us actually see if that is a fit to the organization? Are we just doing it because others are doing it? Is my culture right for it? Am I changing things in advance of going on that journey? How many systems start with the end in mind? What are you trying to solve? What are you trying to achieve? What is the point with this work? And then the key point is, do you have the time to do this? How many of the health systems do actually select the right project team, or we have those folks who are sitting in because they are part of the team and we ask them to do something different? And finally, do we have a full mapping of our value stream? And I ask this question differently because none of these are IT, none of these questions are AI, these are just business operation questions. So I put a few statements or quotes from smart individuals who we know. Mark Twain: whenever you find yourself on the rough side of the majority, it is time to pause and reflect. It is just one of those things where, is there something going on that I should understand better? Second, Albert Einstein said, we cannot solve our problems with the same thinking we used when we created them. Dr. Deming essentially said, every system is perfectly designed to get the result that it does, get. And if you notice, the sub-corollary of this is that most of the times the problems are there not because of individual person action, but because of the system functions. If I look at things differently, I have a few things to share with this group. 3 C's. One is look at human potential as capital, where we use capital to create future growth, future opportunities. Look at forward looking. Second, it is not the technology. Aaron mentioned this at his beginning opening speech, and many of you repeated that in different ways. It is not the technology. And finally, I look at healthcare delivery as a logistics problem. So let's build on it. Recently, there's an article in Science Advances. You can see on the left side, you can search for it. And they did a nice, beautiful comparison. And long story short, this is the key point. I'm going to read this for you. We find that access to generative AI ideas causes stories to be evaluated as more creative, better written, more enjoyable, especially among less creative writers. However, this is the key point to me, at least, generative AI enabled stories are more similar to each other than stories by human alone. This goes back to on what was that model trained. And so it's going to keep on doing the same thing and throwing out the same slightly different ideas because it's generating on the same seed, so to speak. Humans are not that just because we are humans. So the way I look at human potential is align intentionally their potential to true value add delivery. Let these individuals operate at the top of their license. How do you do it? You have different ways of doing it, but that's not the topic for today. Aggressively, if not eliminate, employ automation for non-value added work. That is not making them happy. That does not make any difference to the end product, end result, in this case, the patient we care for. Look at them not as builders, but should be looking at as product managers. They're looking at the big picture and not just the day-to-day, I need to build something for Dr. Keith. Therefore, they become innovators. And when you look at this human potential in that light, it opens up gates. So that's the way I look at things differently. Again, nothing to do with technology. The second piece is this. Many vendors, technology product vendors, are designing a solution or building a product which they have a problem in mind and they solve it. Very few products I know of are problem agnostic. They're solving a specific problem when they make the case to the to their venture capitalists, saying, here's the thing I'm solving, here's the solution to it, because that's what they're doing. But when I look at the product and try to apply it to me, I am now almost looking for a problem to solve with the solution I just purchased. So my point is, if it's the right product we have to buy because there's nothing else, it will always involve how people will do their work, the so-called the people side Aaron mentioned, and how the work gets done differently because the process has changed. So the question I have to ask is, are we building an application, a product, or are we actually solving the workflow, the use case, which is why we are here in the first place? Are we designing just for the blue skies, which is a bunch of individuals saying, this is what I want to do. Okay, here's the way you want to do it. But what if it is not happening all the time? What if a storm comes? Do you know how to manage a stormy state of mind? And finally, are we solving with the human at the center? Human-centered design is taking enough support nowadays in healthcare, but it is not new to engineering. It is not new to industrial engineering. I went to Georgia Tech. There's a school that does this for the last 50, 60, 70 years. So the point is, why is it taking flight right now, or flight right now, I should say? So the way to look at this would be, don't look at this as technology, look at this, what it's trying to accomplish. How will you know this is an IHI model? How will you ask the question? How will we know the change is an improvement? And of course, then do the change. If you don't get the answer because we are in a hurry, we have no time, I don't know how to measure it, ask the question, then why should I do this work? Because if I do this work, something else that is justified, has the outcomes, will not be done, right? We have limited resources. Something will not get done because I said yes to something shiny. So, and the last seed I'm planting is looking at delivery as a logistics problem. Before Shepherd Center, I was with Children's Healthcare of Atlanta. And in one meeting, I was trying to remember what the problem we are discussing. It was an hour-long conversation with MDs and nurses. And at the end of that, I said this actually, there's nothing about technology. There's nothing about patient care. It was a logistical, how do I do this from this to this? It was a process conversation. And so I say this because it's not, I'm not trivializing the healthcare. The person who's doing the task is a clinician who does his or her job at their top of license. But for them to do that action, they need input. They need to do an output. That all is a logistics problem. If you look at it differently, you solve the problem differently. So what does it mean? Do you know the value stream of your work? The value stream, the word is value. Do you therefore then do rapid improvement events to remove waste? Or do you do an FMEA, failure mode effects analysis? You see the acronyms at the bottom. Do you balance the work for efficient throughput? Do you then simplify, standardize, and then you automate that standardized, simplified work? And now you make it easy for the smart clinician to do his or her clinical work. Do you understand the difference between a value add task and essential task? I've had many conversations, folks miss them completely, and I will talk more whenever you want to get a chance. And the difference between an outcome measure and a process measure. Two different things. It changes the perspective. So if you look at logistics and look at how to make it better, healthcare delivery becomes better, and the technology becomes an enabler. So this is something we all know. This is what an FMEA does. It is not just to prevent happening, but how do you design a process that makes it not happen? Design for error is a concept that is out there for a long time, but are we designing for error, or are we just dropping something in place? And one more thing, we cannot be just technology leaders, we have to be educators. I spent today half of my day on meetings where I was not doing any technology solving, but educating my fellow colleagues, the CEO, COO, on what we should do. And I'm not saying it is trivial, I'm not saying easy, I'm not saying that is all we do, but we have to be first creating awareness, educating what's coming up, and then navigate the conversation. So I will skip this slide, but I just want to drop this for a second for each of you to take a moment to read. This is more definition, and I like to understand this before I can make an action on it, is to think is an active, conscious, cognitive process, active, which makes new connections and creates meaning. It is also a dialogue where two things are happening in some capacity, something where internally we are syncing up on all the things we're consuming, and then we don't realize that a give and take is happening unless you're intentionally not, to support your new thinking. You start with one state of mind and you end up with a different state of mind. So with that, I like to say, this is not it. This is a few thoughts I'm planting. I'm sure most of you do this. I'm doing this with intention, with authenticity, and I will not back down until I am backing down. So with that said, I ask that, are we just thinking differently? Is that enough? I don't think so personally, because there's this thing called vision without execution is simply hallucination. So I do not want to hallucinate. I do want to make a difference to the person who I walk out and I see a patient in a wheelchair, and have I made a difference to his or her future condition? They have to go in a different state of mind. They are not going to be normal human beings like what I think. I leave with the following thing, Kate, keep me honest in the time. I was at the recent Peachtree race in Atlanta, and I was able to be in front of the, on the sidelines, if you will, and I saw the first batch, which were essentially wheelchair racers. When I saw one person struggling uphill, we call that as a cardiac hill, I said, I have nothing to complain. And therefore, I am inspired. And with that, I ask us all to think differently. I ask us to debate, challenge me in my perspective. I'm not saying this is right. I'm not saying this is it. I'm simply saying this is a way. Only we think differently, we'll get to a better state. Join me in Dallas with Keith, and we'll make it happen.
Thanks very much. Thanks very much, Atul. We have a couple of minutes if you're okay hanging out. I've got maybe a question or two, and then we'll start to wrap things up. I've been really heartened to hear throughout the 4 sessions, our keynotes, as well as our panel discussions. Yes, this virtual summit is focused on technology, AI, and other, in fact, non-AI related tools and technologies that are really helping us transform health and care out there. But what I heard a lot, and it was continually emphasized, is at the end of the day, it's people, process, and technology, right? And I love what you just shared there. Technology is often simply the enabler. And I think you and I would agree, as with probably most of our participants here today, Aaron, and our panelists, that the most difficult part of the change is rarely the technology. It's almost always the people in the process, right? So help me with this question. I'm seeing organizations out there who are grabbing AI, they're implementing AI, they're piloting AI, expecting that this technology is going to be the panacea or the cure. And they're not focusing enough on the people and the process sides of the change or the transformation that they're hoping to affect. Why do you think this is happening? Like, we know better, right? We know better, but it's still happening. Why do you think that is?
It's a deep question. We should meet in Dallas to think this through, but I'm not promoting charm necessarily, but it's a deep question. And I'll say the following. I think it is an easy button. I think it is very hard to move the cheese and expect somebody to say, okay, bring it on, I'll do this differently tomorrow. It's not. We ourselves don't like it. So I think it's an easy button, and therefore the inertia sets in, and therefore we want to avoid it. It's a path of least resistance. It is like water. It will eventually reach its destination. It will go around rocks and eventually reach the sea, if you will, from the river. But the idea is it will find a small, I think that's one. And the second thing is, I said the educator, right? I have to do my job of educating and holding the line, so to speak, saying, what about people? What about the process? And I think finally, I would say a little bit on the fact that vendors are coming, partners, I should say, are coming to us saying, we can do this for you. It's easy, it's turnkey, and lo and behold, it doesn't. And so it becomes a promise that doesn't reach, and by the time you're already committed and now you cannot go back, it's complicated. So it's a deep question. I'm not saying I have the answer, but I'm glad you asked for it.
Thanks very much, Atul. Let me again thank our closing keynote speaker, Atul Kavinde, CIO at the Shepherd Center. Atul, it was a lot of fun. Thank you for joining us. There's much more for us to dive into. Atul is a faculty member for our upcoming Fall Summit, Think Differently, taking place in Dallas, September 11th through the 13th. We hope you will join him, our host, John Manis, and many other Chime colleagues. We look forward to seeing you there. Don't leave yet. We've got a couple more things we want to cover. Atul, thank you so much for joining us, my friend. We'll see you soon. I just want to thank everybody for joining us today. Really a special and heartfelt thank you to our opening keynote speaker, Aaron Mary. Love you. Thanks you for joining us, Aaron. Our panelists, Terry Couts, Chira Goswami, Jacob Hansen, Dr. Engers Fernandez, and Laura Kriowski, and of course, our closing keynote, Atul Kavinde. Appreciate you all for joining us, taking time out of your day today to really add some depth to the conversations around AI, cyber, and everything else that's out there that we're tackling on a day-to-day basis. Huge thanks to our production engineer, Luke Skaggs, the guy behind the scenes who did an amazing job creating overall a very seamless experience, and to the Chime team, also behind the scenes, who supported so much of this work and helped us bring the virtual summit to you. For those of you who weren't able to catch all of the sessions today, we'll be delivering links to the recorded sessions to all of our registered attendees. If you're only able to catch parts of it, you'll of course be able to catch up with all of the recordings. Thanks again for participating. We hope you found value in the conversations today, and we hope to see you more at future Chime innovation programs. I would be remiss if I didn't mention the virtual summit. Simply would not have been possible without the amazing support of our sponsors, AvaSure, Microsoft, and Nordic. Thank you again for your gracious and generous support. We appreciate all that you do out there to support health and care and digital health leaders who are working hard every day to transform the healthcare delivery process. Another shameless plug for the September Innovation Summit. If you enjoyed the virtual summit today, I hope you'll consider joining us in Dallas, Texas, September 11th through the 13th on the Christus Health Innovation Campus. For our fall summit, we're going to continue this theme, think differently, and that mindset, more importantly, as Atul says, do differently. This in-person event is graciously hosted by Christus Health CIO and Chime board member, John Manis. John, thank you for inviting us into your beautiful and amazing innovation center and campus. The program is available to all members of Chime, AHIS, AHIT, and IHATA, as well as non-member provider executives who are interested in driving innovation and learning more about the Think Differently mindset. So whether you're a Chime member or another provider who's joined us here today, interested in innovation, interested in learning more about the Think Differently mindset, we hope you'll consider joining us in Dallas, Texas. It's also available to a limited number of executives from our program sponsors. So whether you're interested in attending or sponsoring, follow that QR code that you see on your screen there. Get yourself registered. Sign up. The last Innovation Summit that we held in May was completely sold out. We had no more room and we had a lot of demand. So if you're interested in participating in this summit, don't wait. Follow that QR code. Get yourself registered. We'll look forward to seeing you there. And next up, let's talk quickly about the Chime 24 Fall Forum. Mark your calendars. November 4th through the 8th. We're going to be in sunny San Diego. Technology, as we heard today, is evolving at a rapid and accelerating pace. In order to keep up with those changes, it's important that we connect, come back together as a community, spend time with our peers and our solution providers, and work together to inspire each other to really transform health and care. We hope you'll join us in San Diego, shape the future of healthcare at the Fall Forum. Registration and housing is open now, so go ahead and grab your Fall Forum ticket and book your room now, as we're expecting very strong demand for hotel rooms. And we, in fact, ran out of hotel rooms in our block last fall. So if you're going to join us in San Diego, don't wait. Go to chimecentral.org, grab your ticket, book your room, and we'll look forward to seeing you there. And we've got more coming. A number of upcoming events. One in particular I want to really highlight. That's our brand new CXO Leadership Academy. If you're one of the more than 4,500 graduates of Chime's Healthcare CIO Bootcamp programs, this program, the CXO Leadership Academy, is the answer to the most common question we hear after a bootcamp ends. What comes next? And well, we've developed what comes next thanks to our Senior VP of Educational Learning, Nicole Kirkenbush. This intensive 2.5-day executive education program designed to train and prepare the next generation of digital health leaders to successfully meet the demands of these critical positions. Chime membership is not required to participate, and the program is open to more than just CIOs and CDOs. You're a chief AI officer, chief medical or nursing informatics officer, chief health information officer. Many other executive levels out there are in the midst of this digital health transformation. This program's for you. And finally, mark your calendars for February 16th through 19th in 2025 as ViVE moves back to Nashville. We know it's going to be a heck of a program. Nashville was a huge hit 2 years ago. We're excited to be coming back. Remember, ViVE is the only industry event that's focused exclusively on the executive level experience. There's no other event like it. If you haven't been to ViVE, we hope you'll consider joining us in Nashville. And if you've been to ViVE before, we definitely look forward to seeing you again in Nashville. Registration is open now for ViVE, so join your industry peers at the only digital health event focused exclusively on you. With that, I want to thank everybody for coming. Thank all of our guests, our speakers, our panelists today, Luke and the Chime team behind the scenes. Thank you. And we look forward to seeing you at a future Chime Innovation program soon. Be well.